Chapter 6, Anatomy and Physiology. So this chapter is going to be a little bit different. There are 75 slides. I'm not going to cover all of them because at the end of the day, most of the content is printed pretty clearly on the slide. You can review that along with your textbook, and you're going to derive the same information as if I were to talk about it. However, the fact that there isn't a lot of discussion to be had should not represent the fact that there is an incredible amount of information contained here. You will be responsible for knowing the primary and secondary functions of every major body system in the body. We're going to go through that, but it's really important that you understand that you should be spending a ton of time on this chapter. You need to be able to recite primary and secondary functions of every major body system. And that's going to require a lot of studying, a lot of memorization. And that's all going to apply throughout the remainder of this class and the remainder of your career. So diving right in, let's jump ahead to the body systems itself. Now, I just told you that you need to know primary and secondary. And as a matter of fact, I said that twice. There's a reason. It's important. So here it gives you the three main functions of the musculoskeletal system. Give the body shape, protect vital and internal organs, and provides for the body's movement. Now, when we look at the word musculoskeletal and we break it down, you'll see that there's really two combined systems there, right? We've got the skeletal system and the muscles combined to make up the musculoskeletal system that provides for the functions listed there. So I want to skip ahead to the next image here. When we come across these types of things, we need to really take some time to look at it. You will be required to label each and every one of these components at one point or another. It's important that as we are performing assessments on our patients that we can look at this, we can identify the location of an issue and accurately describe that. So yes, we could simply say the patient has a laceration to the right lower jaw. However, it would be more appropriate to say the patient has a laceration to the right mandible and describe it that way. Using the appropriate terms, what it does is it allows us to accurately describe things, accurately communicate things without risk of misinterpretation or potentially confusing somebody. The spinal column itself has 33 vertebrae. So this is kind of interesting because when we think about the spinal column, we oftentimes associate that with the spinal cord, when in fact they're two completely unrelated items. Now, granted, the spinal column does house the spinal cord, and it's in existence there not only as a support structure, but also to protect the spinal cord. But they are essentially disassociated. The spinal cord itself does not travel the entire length of the spinal column. We'll talk more about that when we get to the back and spine trauma chapters, but it's important to understand that just because we're referring to, let's say, a broken back or a fractured vertebrae, that does not necessarily mean that there's any damage to the cord itself, which is where we would get some of the pretty life-threatening neurologic issues. The thorax is also interesting because we typically think of the rib cage as being the thoracic cavity, and in fact it's really not. The diaphragm divides between the thoracic and abdominal cavities. And what happens is the diaphragm comes up just below the xiphoid process, right at the base of the sternum. And as it comes across, both the liver and the spleen are recessed up underneath the rib cage to an extent. So what that means is that the rib cage itself should not be a descriptor for the thoracic cavity, but rather we need to understand what the anatomy is beneath the skin and make sure that we're assessing the appropriate cavities. Why do I emphasize this? Because I've seen people listen to lung sounds over the spleen. They think that because they're over the rib cage, there must be a lung there, and that's not the truth at all. So really know your anatomy, know where your different landmarks are at, and be sure that you're performing your assessments appropriately. The axial skeleton here is broken down. So we've got the 33 vertebrae, and that's divided into the cervical spine, thoracic spine, lumbar spine, and then we have the sacrum and the coccyx. So again, understanding the differences there is important. The different spinal nerves that come off the cord there exit at different vertebrae, and it's important that we understand, based on a certain trauma location, what are the potential neurologic outcomes that we have to deal with. For instance, the spinal nerves that branch out in the cervical spine around vertebrae 3, 4, and 5, they branch down and they control a lot of our respiratory function. So if I have a spinal cord injury to the cervical spine, specifically involving vertebrae 3 through 5, then we have the risk for pending respiratory issues. So again, some additional anatomy of the musculoskeletal system. Be sure that you're going through all those things. You'll notice here what we typically refer to as toes are actually going to be referred to as phalanges. Same thing applies to fingers. So go through, know the appropriate terminology for all these different items. And although looking at it on the slide doesn't help out much, when we look at diagrams like this, it does help us to identify the location of everything. So then we have two different types of joints, ball and socket and hinge joint. Think for a second, what are some examples of those two different joints? Now I can think of the knee. The knee would be a great example of a hinge joint, whereas where the arm comes up to the shoulder, that would be a great example of ball and socket. Anywhere that you can have rotation, right? You can kind of spin something into a circle, you know you've got ball and socket. Anything that just simply moves one direction or the other would be an example of a hinge joint. So again, not only the knee, but also the elbow would be examples of hinge joints. Now there's different types of muscles in the body. When we think of muscle, we typically think of going into the gym, lifting weights, building up our biceps, and looking impressive at the beach. In fact, while that is a component of our musculoskeletal system, and it does help us with strength and stability, there are tons of additional muscles that are working behind the scenes at all times that are functioning to keep us alive, not just make us look good at the beach. So our voluntary muscle is our skeletal muscle, and that's what we just described as being, the muscles that we go to the gym and try to work out. Involuntary muscle is called smooth muscle, and that surrounds our blood vessels. It surrounds our digestive system. Smooth muscle, it surrounds our bronchioles. Smooth muscle is located throughout the entire body. It's part of our esophagus that helps us to swallow food. Smooth muscle is everywhere. And the reason that's called involuntary is because that all functions without us having to think about it. If I decide that I want to jump up and down, I have to use my leg and back muscles in order to do so. That's a voluntary process, and that's why those skeletal muscles would be what I would use. However, I don't have to think about the process of digestion. If I eat, then my body automatically processes and digests that food without me having to think about it. Therefore, that's all involuntary or smooth muscle. Cardiac muscle then is the third type of muscle. The only place the cardiac muscle is located is in the heart itself. And what's unique about cardiac muscle is automaticity. So automaticity means that each and every cell within the heart has the ability to generate its own electrical impulse. Now this is in effect because it serves as a backup system. While we do have a pacemaker of the heart, it's called the sinoatrial node, and that pacemaker should keep the heart firing at a consistent rate on a regular basis and allowing our heart to pump an efficient amount of blood. There are times that pacemaker goes down, that it stops working. So through automaticity, we have the ability to generate excess electrical impulses to try to survive if necessary. But the other benefit is, as that electrical impulse is transmitted from the sinoatrial node, each one of those cardiac cells picks up that impulse and then transmits it to the next cell over there. And it allows that electrical activity to be transferred throughout the heart very, very quickly. So there's some images of the different types of muscle. Respiratory system. I think most of us could probably take a solid guess as to what the respiratory system does, but believe it or not, it actually does quite a bit more. So here it says brings in oxygen, excretes carbon dioxide. I think that would be fair to say that that is the primary function of the respiratory system. However, it also helps us to get rid of excess heat. The most heat is lost through the respiratory process. Now, that is a good thing when we are overly warm. We can increase our respiratory rate, try to get rid of that excess heat, in addition to things like sweating and stuff like that. But it just goes to show again that everything has primary and secondary functions. We're going to go through respiratory anatomy extensively in class. You should be familiar with everything, but we'll actually go through some different mannequins and models, and we'll practice not only identifying but discussing what the function of each one of these things does. So the larynx. Larynx is it's at the top of the trachea itself. just below the glottic opening, and that's where your vocal cords are at. Now, if you were to place your fingers on right over what would be the Adam's apple, which is not a medical term, by the way, and we start to speak, we can actually feel vibration going on through the vocal cords there. And that's how we generate sound. As air passes the vocal cords vibrate, they create that vibration is then transmitted through the air, and then the ears are able to interpret that from other people. So that's how we interpret sound, is actually through sound waves themselves. So it is safe to say that if somebody is unable to speak effectively, that there's a good chance that they may have some type of respiratory compromise, specifically an airway obstruction or something like that. If we're not able to move air past our vocal cords, we would be unable to speak then. So again, some additional diagrams. I will spend some time talking about inhalation and exhalation. So inhalation being an active process, that means that we use energy, we use muscle in order to breathe in. And what happens is we have intercostal muscle that is in between each and every one of our ribs there. The intercostal muscle flexes and it draws our chest outward, all right? It expands our chest cavity. At the same time, the diaphragm flexes and it flattens itself out. So the diaphragm in a state of rest is actually kind of arched, but when it goes to contract, it flattens itself out. And between that happening and the intercostal muscles pulling the chest out, it opens up the air cavity within the chest, creates a negative pressure. Air from outside the body then rushes into the chest to balance that out, okay? Everything in life is about balance, and we'll talk about different types of balance extensively throughout the semester. But this is one of the first examples. So the air pressure outside the body should be the same as the air pressure inside. When I expand the air cavity, then that creates a negative pressure, draws air in to balance out. Now, when I go to compress my chest cavity, and the ribs rather, they compress back down as those intercostal muscles relax. The diaphragm relaxes and it pushes back up toward the xiphoid there and arches itself. Now all that air inside my chest is compressed. Because that compressed air is now at a higher pressure than outside my body, the air rushes back out to try to equalize. And that's the process. But remember that because I have to use muscle to expand the chest and I have to use muscle to flatten the diaphragm, those are all active processes. That's where I'm using energy to supply those muscles in order to do their job. When I breathe out, though, the exhalation process, that's considered passive. Reason being, again, because all of the muscles are just simply relaxing. As they relax, everything by default compresses, and then it pushes the air out in order to equalize the pressures. So a little factoid here, ventilation versus respiration. Ventilation is a mechanical process. So as my chest expands and my diaphragm flattens and air is moving in and out, that is the mechanical process of ventilation. Okay, moving air from outside the body inside into the lungs. The process of respiration, though, that's the actual exchange of gases. So once air gets into my lungs down to the alveoli level, the exchange of gases between the capillaries, that's the process of respiration. Now, I want you to think about this. Can I be ventilating without respirating? And the answer is yes. So I could easily move air in and out of the lungs without any ventilation occurring. Congestive heart failure would be an example of when that may happen. So even though air is moving in and out of the lungs, because fluid exists inside the alveoli there, the respiration process is blocked, right? We cannot diffuse air through water. It just doesn't work. So as a result of that, we need to be assessing both ventilation and respiration quality. And why do I say that? Well, what if the patient has a respiratory rate of 20? We know that the normal resting respiratory rate for an adult is 12 to 20. If they have a rate of 20, it seems pretty good, right? Shouldn't be a problem. But what if I told you that they have a rate of 20 and they have pulmonary edema, preventing respiration from actually occurring? When we describe the word or the term respiratory rate, we assume that if their chest is rising 20 times, that there would be 20 exchanges of gas at the same time. But in fact, that's not necessarily the case. So a patient with a ventilatory rate of 20 may not be respirating very effectively at all. And how would we identify that? How could we figure out that, okay, my lungs are doing one thing, but I don't think it's being effective? Well, we could look at their skin parameters. Would they be pale or cyanotic? We could look at their overall mental status. We could look at indications of anxiety. Anytime we're unable to breathe, anxiety naturally kicks in. It's part of our fight or flight mechanism. So all of these things tend to happen. We need to look beyond chest rise. All right, and I know that previously you were taught to evaluate chest rise to determine whether or not a patient is breathing effectively. That is simply one component, but we need to be looking at the big picture now. So the physiology of the respiratory system is pretty simple. Physiology meaning what process does it follow? And it's going to take the oxygenated blood from the lungs, from the capillaries surrounding the alveoli. It returns that oxygenated blood back to the heart. The heart pumps it out to the rest of the body, and that oxygen is then dispersed to all the different cells and tissues. From there, then, deoxygenated blood comes back to the heart pumps that back to the lungs, and it goes through the same process again. A couple things to think about when we talk about anatomy between children and adults. So this is really, really important, and you'll see this on several exams. A child, although if you notice here, their tongue is smaller than the tongue of an adult, the amount of space that their tongue occupies within the oral cavity here is substantially larger. So you see here in the adult we have a bunch of excess space, and in the child we don't. What that means is that this tongue acts as an obstruction more times than it doesn't. It's really important that when we're dealing with kids, we maintain a neutral airway alignment. Now, the other thing to consider too is, this child that's pictured here is older, probably, my guess would be maybe 7 or 8. But at the younger stages, their head is significantly larger in proportion to the rest of their body. So we may need to pad underneath their shoulders in order to maintain that neutral alignment. Other things to think about here is we have cartilage that surrounds the trachea, and that cartilage hardens over time. So for a newborn baby, that cartilage has not hardened yet, and if their head were to be pushed forward and kink off this trachea, it kinks off the trachea like a coffee straw would be, and it can include the airway. Whereas with the adult, that cartilage is hardened here. So even if this adult were to take their chin and put it to their chest, that cartilage keeps the trachea open, and although they're not able to move as much air, they're still able to breathe and even speak. So everything here that's discussed, we want to keep that stuff in mind when we're assessing and treating children, and we may want to keep it in mind for future exams. So the cardiovascular system, again, let's look at that word cardiovascular. That tells me that it's going to be a combination of both the heart and the vascular systems together, and they work together. Let me point this out too. What about CPR? Cardiopulmonary resuscitation, right? So we're taking the cardiovascular system, we're taking the respiratory system, and now we're trying to resuscitate both of those systems combined. So remember, if you ever get hung up on what something is or what it does, take a look at the root words and try to figure out, from there, what it's actually suggesting. So cardiovascular system, heart, blood, and blood vessels. We should know by now that the heart has 4 different chambers, 2 upper atria, 2 lower ventricles, and then we will discuss the pathways throughout the heart more in class. But I would strongly suggest that you watch plenty of videos, that you look at plenty of pictures, and that you be able to recite without hesitation the direction that blood travels throughout the body. So for instance, I can tell you that deoxygenated blood returns to the heart through the superior and inferior vena cavas. From there, it drains into the right atria. The right atria contracts, forcing blood into the right ventricle. The right ventricle then contracts, pushes blood out through the pulmonary artery. Pulmonary artery travels to both lungs. The blood receives its oxygen supply in the lungs and then travels back to the heart through the pulmonary vein. The pulmonary vein comes together from both lungs, drains into the left atria. Left atria contracts, forcing blood into the left ventricle, and the left ventricle then contracts, pushing blood out through the aorta and dispersing it to the rest of the body. You need to be able to recite that. You need to be able to identify those anatomical structures in a picture or diagram. That is one of the most important things that you need to get or take away from this chapter here. So here's a great picture with arrows. It's even got numbers that show the direction and travel throughout the body, so I would probably use this. We're going to take a quick second and watch a short video on the blood flow of the heart, and keep in mind that YouTube should be your friend. Always take time if you need additional reinforcement to YouTube a video if necessary.
The heart is a pump which must circulate blood through two different but interconnected vascular systems. The smaller of these systems is the pulmonary system. Blood returning from the upper part of the body is delivered to the right atrium of the heart by the superior vena cava, one of the body's two largest veins, while blood returning from the lower part of the body is delivered to the right atrium by the other major vein, the inferior vena cava. Contraction of the right atrium in each cardiac cycle forces blood into the right ventricle. This is followed by contraction of the right ventricle, which pumps blood into the pulmonary artery, sending it on through the blood vessels of the lungs. As the right ventricle contracts and pressure within the right ventricle rises, the tricuspid valve situated at the opening between the right atrium and right ventricle shuts, preventing any backflow. The pressure generated by contraction of the right ventricle soon opens the pulmonary valve and blood enters the circulation of the lungs. After passing through the circulation of the lungs, the blood, having been recharged with oxygen and having rid itself of carbon dioxide, is returned through the pulmonary veins to the left atrium. The left atrium, too, contracts, forwarding blood into the left ventricle in order to fill it before it contracts. As the powerful left ventricle contracts, the mitral valve shuts, preventing backflow into the left atrium. The aortic valve opens, and blood is forced into the aorta, which distributes it to the rest of the body apart from the lungs. As the contraction comes to an end and pressure in the aorta falls, the aortic valve snaps shut to prevent backflow into the left ventricle.
All right, so that was a nice little illustration, a nice video of how the blood travels through the heart. This year as an EMT, we'll also begin talking about the cardiac conduction system. Now, you won't really do much in the way of rhythm interpretations until paramedic class, but I am going to give you a little basic introduction, both through this presentation and also in class, so that you have some introductory understandings of it. So the sinoatrial node is the pacemaker of the heart. That is contained in the right atria. I'm going to say that again, just in case you see that on an exam somewhere. The sinoatrial node is considered the pacemaker of the heart, and it's contained in the right atria. I would keep that in mind. So what happens is the sinoatrial node generates this electrical impulse. That electrical impulse travels through these internodal pathways here that you can see kind of I think that's yellow. And then from there, although this is kind of a pathway for the electricity, it then branches out to all the different cardiac cells that line up next to it. And that electrical impulse is transferred from cell to cell, and together the atria then contract. Beyond that, then that electrical impulse traveling through the internodal pathways comes to this atrioventricular valve. Now again, looking at atrioventricular, if I said, hey, what's the location of the AV node or atrioventricular node? Then you could look at atrio, you could look at ventricular, and it's safe to assume that maybe it's right between the atria and the ventricles, which is exactly where it's at. So it receives this electrical impulse, it grabs onto it for just a split second, and then it releases it down into the ventricles. And from there, it travels down through these bundle branches, and it branches off into what are called Purkinje fibers. And again, these are just little tiny pathways that deliver the electricity a little bit more efficiently. And then from there, all of the cells inside the heart muscle itself pick it up. They transfer from one cell to another, and collectively they contract all at one time, forcing the blood out of the ventricles. As long as this cardiac conduction system is working effectively, our cardiac output should be working pretty well. However, there are times that it could still be interrupted. So while you're not going to be interpreting rhythms, you will have to have a general understanding of how the cardiac conduction system plays into the actual mechanical process of pumping blood. So you may want to know these arteries. One, because it's going to be on an exam. but two, because these are really relevant when we're doing patient assessment, and they tell us a lot of different things. So the coronary arteries surround the heart. Those arteries actually supply the blood to the heart that it needs to live. The blood that goes through the different chambers of the heart does not actually perfuse the heart. The blood has to go out through the aorta. From there, the blood travels from the aorta into the coronary arteries. The coronary arteries surround the heart, and all of the perfusion of the heart muscle is done through those arteries on the outside of the heart itself. The aorta we kind of talked about, right? That comes out the top of the heart there. Pulmonary artery. So pulmonary meaning the lungs. Pulmonary, and it's an artery, so that means that it's traveling away from the heart. Pulmonary artery takes the blood and it sends it over to the lungs. Now, this is a unique artery in the fact that it is the only artery in the entire body that carries deoxygenated blood. Normally, if we see an artery, that signifies to us that the blood inside that vessel has oxygen inside of it. In this case here, the pulmonary artery is taking blood from the heart over to the lungs. So as a result, it doesn't have any oxygen. That's why it's going to the lungs, is to get some. So the pulmonary artery is the only artery in the body that does not carry oxygenated blood. The carotid artery travels from the tops of the aorta all the way up to the brain, and those are what travel through the neck there. When we feel a carotid pulse, that's what we're actually palpating. And the femoral artery is what supplies, it's a major artery that supplies the legs. So same thing, we can assess a femoral pulse down in the groin area there. What that does is it signifies to us the quality of perfusion to the lower extremities, but it's also a way of identifying overall perfusion quality to the rest of the body. If I don't have femoral pulses on either side, that tells me that the blood pressure is so incredibly low that it's having a hard time perfusing most structures of the body, and we should assume that the patient is decompensating and that we need to take some immediate interventions. Some other important arteries to know: brachial artery. Brachial artery is just behind the bicep in the upper arm, and that's an artery that we're going to assess on children. It's a lot easier to palpate that artery than their tiny little radial arteries would be. Radial artery itself, speaking of the devil, is what's in our wrist. That's what we are typically going to use to assess pulse rate and quality in our adult patients. The radial artery is used because of a few reasons. One, if we are able to develop a strong radial pulse, then we should have enough blood pressure to adequately perfuse the entire body. The other thing that we're looking at, though, is as we assess a radial pulse on a patient that would be conscious and alert, it's a non-invasive area of the body. So that it's no different than a handshake or something like that. For me to kind of reach out and simply assess their radial pulse is not a big deal. Compared to if I have a patient, again, who is conscious and alert, and I walk up to them and I wrap my fingers around their neck to start assessing the carotid pulse. A little less appropriate, a little less professional in that case. So we do use different pulse points for different purposes. Radial artery would be, again, on conscious and alert patients. But if the patient was unconscious and we were assessing for a pulse to determine the need of CPR, then yeah, we would go straight to that carotid pulse. So keep those in mind. There's a reason that we do everything, and think about that practically. Why would it not be appropriate to assess the carotid pulse on a patient who is conscious and alert? But why would it be necessary to assess that carotid pulse on an unconscious patient? Posterior tibial dorsalis pedis. Dorsalis pedis, if you look at that, is not something that you can really figure out exactly where it's at. But if we break down some of our medical terminology, dorsal means back of, right? Pedis is actually the term for foot. So that is on the back, or in this case, the top of the foot. And checking a pedal pulse is something that we'll actually do relatively frequently, especially if we have an injury to one of the lower extremities. Then we would assess that pedal pulse to determine if we have any interruptions to the distal circulation. So our capillaries, our veins, and our arteries, this is something that's important to know. Our arteries carry blood away from the heart. And with the exception of the pulmonary artery, every single artery in the body carries oxygenated blood. That oxygenated blood comes down through the artery, and then it goes through this capillary bed. Capillaries are tiny, tiny little things. And capillaries are the only point in the body where gas exchange can occur. So in order for oxygen to get out of the blood vessels and into the cells, it has to happen at the capillary level. So again, oxygenated blood comes through the arteries, goes into it goes into smaller arteries called arterioles, and then they branch into the capillary beds. Capillary beds allow for the gas exchange to occur, so oxygen goes out into the cells, carbon dioxide comes back in to the capillaries, and then from here we go back through tiny little veins called venules, back into large vessels called veins, and then this deoxygenated, or in this case, carbon dioxide rich blood is traveled back to the heart and then eventually back to the lungs to be exchanged once again. So, capillaries are the only spot in the body where gas exchange can occur, and that even holds true for the lungs. Remember that it's capillaries that surround the alveoli and allow for the gas exchange to occur. The composition of blood, as you see here, 4 different components: plasma, red blood cells, white blood cells, and platelets. Now, obviously, there are lots of other things that are traveling through blood, nutrients and stuff like that. But generally speaking, the blood itself is made up of those 4 components. Now, those bold underlined terms are like that for a reason. You will be tested on those. A red blood cell is also known as an erythrocyte, tongue twister. Again, a red blood cell is known as an erythrocyte. White blood cells are known as leukocytes, and platelets are known as thrombocytes. So the plasma is the liquid of the blood, and the plasma is essentially made up of water. The red blood cells then are exactly those little tiny cells that are red in nature, and those allow the oxygen to bind to it. So on the red blood cell is something called hemoglobin. And the hemoglobin is what the oxygen can bind to. So as the oxygen binds to the hemoglobin, it transfers it throughout the blood, delivers it to where it needs to go. Now, of interesting note, and we'll talk more about this when we talk about vital signs, but the hemoglobin on the red blood cells, that's what we're actually assessing with the pulse oximeter. So when we put that SpO2 monitor on a patient, and we put that little thing on their fingertip, the infrared light is assessing the saturation of the hemoglobin. Now, we assume under normal circumstances that the hemoglobin is going to be saturated with oxygen because that's what it's intended to do. So if I get a 98% SpO2 reading, that tells me that I should have 98% of the hemoglobin saturated with oxygen. However, it is possible that something other than oxygen binds to it, as is the case with carbon monoxide. Now, notice the difference between carbon monoxide and carbon dioxide. Carbon dioxide, CO2, is actually something that's naturally produced by the body, and it's something that we excrete. No big deal. Carbon monoxide, though, with an M, is a byproduct of incomplete combustion. So it's something having to do with maybe your furnace or stove or other gas products. And what happens is the carbon monoxide gets into your body, binds to the hemoglobin, and it blocks the oxygen. So with a carbon monoxide poisoning, if we go to assess that patient and we look at the SpO2, they could again be at 98%. And while we would normally think that that's a good level to be at, in fact, what we're looking at is saturation of the hemoglobin with carbon monoxide, or CO, which is going to be a deadly thing. So we need to pay close attention to that when we're assessing our patients. The white blood cells, or leukocytes, those are always present. They help to fight infection. But when we are sick or when we have a widespread infection, white blood cell counts typically increase. Platelets then are what we use for clotting. Those thrombocytes form together. They have little fibrin within them. They form those clots, and that's what will help stop internal bleeding. So the pulse. Pulse is different than heart rate, and that's something that's really important to understand. If I have somebody on a cardiac monitor and I'm watching their heart rate on the monitor, and it shows me a number and it says that their heart rate is 92, that's fine. Their heart rate, meaning the electrical conduction, is occurring 92 times per minute. However, that does not, although it should. Heart rate should be the same as pulse rate. In certain sick patients, that's not necessarily the case. So I always want to be able to discriminate between heart rate and pulse rate. The only way that I can identify what the pulse rate is by physically touching my patient and feeling or palpating the pulse on their body. So if I apply my two fingers to their radial pulse site on their wrist and I count the number of times that I feel that thud, that is me assessing pulse. And if that happens 92 times a minute, perfect. If their heart rate on the monitor is also 92 times a minute, then we know everything is working like it should. Again, in certain sick patients, though, that might not be the case. And that's something that's a discussion for another day. Different pulse points are used at different times for different purposes. Again, you'll see their radial, brachial, posterior tib, and the dorsalis pedis pulses are considered peripheral, meaning that they're kind of far out on the body. And we can use those as assessments of not only blood flow to the extremities, but also overall perfusion quality. If I can generate a radial pulse or if I can generate a pedal pulse, I know that I'm delivering an effective amount of pressure between the heart and those very distal points there, and it should be able to perfuse the entire body. In the absence, or if one of those pulse points are very, very weak, it may be appropriate to go back and check a central pulse point somewhere in the core of the body. Now, there's much less blood pressure required to generate a pulse point at those sites. So if the patient is in a decompensated state of shock, their blood pressure is down, we may not be able to assess a radial or a pedal pulse. But I can go back to the carotid or femoral pulse points, which is going to be a little bit easier to assess. If I don't have a radial pulse, but I do have a carotid pulse, that tells me, okay, good, their heart is functioning, but it's probably not functioning effectively because they don't have a high enough blood pressure to perfuse those distal parts of the body. So I am going to start to see some damage to the tissues occur as a result of that. So this slide just kind of summarizes what I just talked about as far as the quality of the blood pressure and pulse points themselves. Blood pressure. So we'll talk extensively about blood pressure. We have an entire chapter just strictly on perfusion. The systolic pressure itself is the upper reading. So when we say 120 over 80, systolic pressure is the 120. And the systolic pressure is the amount of force applied to the walls of the vessels when the left ventricle contracts. So as the left ventricle, the heart constricts and it pushes blood out forcefully. The amount of pressure that's exerted against the artery walls there, that is our systolic pressure. The diastolic pressure, or the bottom number in our blood pressure, is the amount of pressure that is residual, the amount of constant pressure that's in there. So when the heart is at rest and it's not forcefully constricting at the time, what is the pressure that is against those vessel walls? And again, we would describe that as our diastolic. So in the example of 120 over 80 for a blood pressure, diastolic pressure being 80, there's always 80 millimeters of mercury of pressure exerted against those vessel walls. That's what happens when the heart is at rest. It's a constant pressure. When the heart does constrict, it has to constrict forcefully enough to overcome that diastolic pressure. And it typically will constrict in a way that we should see pulse point gaps between 30 and 50 points. And in this case, 120 over 80, it's about a 40-point gap. And that's pretty standard. So the left ventricle will constrict forcefully to overcome the diastolic pressure, forcing the blood out of the heart, creating this pulse wave, and that is the systolic pressure. When I am assessing or palpating a pulse, no matter what point it be, radial, femoral, carotid, doesn't matter, as I feel that thud every time the heart beats, that is the systolic pressure. That is a pressure wave coming through as a result of the left ventricle constricting. And if I can measure that pressure effectively, that would be a measurement of the systolic pressure. So perfusion, again, an entire chapter just on perfusion. Perfusion itself is the adequate circulation of blood and exchange of oxygen and waste products. Perfusion has to occur at all times. Anytime we get into a hypoperfusion state, we would describe that as being in a state of shock, and tissue damage is going to result. Obviously, in the most extreme circumstances, when damage to the heart, lungs, brain, or other vital organs begins to occur, then death can ensue. So we are always measuring or assessing our patients for effective signs of perfusion. So the life support chain, interaction of respiratory system and cardiopulmonary system. And we talked about this a little while ago, right? The the heart and the lungs themselves, they have to work cohesively together because the heart does a good job of circulating the blood. The lungs do their job of exchanging gases. If either one of them fails, if they break down or if they fail to work together cohesively, then the body itself suffers and we'll start to see significant decreases in our patient's conditions. And in this case here, a lack of perfusion would mean that we're not getting enough oxygen to the cells, and it also means that we're not getting rid of all the carbon dioxide and waste products. As that carbon dioxide continues to build up because we're not able to get rid of it, the body goes into an acidotic state. We'll talk a little bit more in perfusion about the pH balance, but essentially our body has to remain almost perfectly balanced at all times. And anytime we start to fall out of balance, we can get very sick, and again, death could be a consequence. So the lymphatic system here. Woo! Lymphatic system, and I'm sure you guys have heard of lymph nodes before, that essentially delivers all the different fluids throughout our body. It can help us retain fluid. It'll deliver fluids to areas that are fluid depleted, and it maintains our overall balance there. There are little lymph systems, little channels that deliver fluid from different areas of the body, all the way. It's like a little highway system within the body itself. Very, very important. Not something we hear about very often, but I'm sure you guys have heard of cancer patients who have developed, systemic cancer where it got into the lymph nodes, and then all of a sudden, bam, it's disseminated throughout the entire body, and typically something that's very difficult for them to come back from. So a few different organs that are related to the lymphatic system: adenoids, tonsils, spleen, thymus, and nodes. So ironically, I bet there's a handful of people listening to this that have had their adenoids or their tonsils removed, maybe both. I know my 6-year-old son, he's had both of those removed at one time. So although they do serve purposes, we also know that they can become inflamed, they can become infected, and especially in the case of adenoids and tonsils, those constant infections, throat infections, and stuff like that can be more detrimental than good, so they choose to remove those. So avoid taking blood pressure on the side of a woman's body where a mastectomy has been performed. A mastectomy is where a breast has been removed, typically as a result of cancer. This is actually kind of old school though, because the new procedures for doing mastectomies, they don't interfere with the vasculature and the lymphatic system like they used to. So the patient will more than likely be able to tell you, yes, you can take a blood pressure here, or no, you can't. But if a patient has had a mastectomy performed, it is generally good practice to take a blood pressure on the opposite side. Now, what typically happens today when a mastectomy needs to be done as a result of breast cancer, if you're going to take one, you might as well take them both, right? Better to play it safe than sorry. So a lot of women have a double or bilateral mastectomy, and when that happens, we don't really have a choice, right? We're going to take a blood pressure on one side or the other. So don't let this don't let this bother you too much. Be aware of it. Be cognizant. Ask a patient if they have a preference on which side their blood pressure be taken, but typically not going to harm the patient if we do it on the same side as the mastectomy itself. Nervous system. You could probably spend an entire semester simply talking about the nervous system. So much going on here. We're just barely going to graze the surface in this class. But as you can see, the main components of the nervous system, being the central nervous system, are the brain and spinal cord, and then we have our peripheral nervous system, which is all the nerves that branch off of that. So there you go. Central nervous system, brain and spinal cord. Peripheral would include all of your sensory and motor nerves. We also have the autonomic nervous system, which controls all of our involuntary motor functions. Moving on to the digestive system. Digestive system is exactly what it sounds like. It aids with digestion, allows our food to be processed, absorbs the nutrients, absorbs necessary amounts of water, excretes waste product. So obviously that starts as we eat our food, travels down the esophagus, enters into the stomach. Beginning in the stomach there, we start to see chemical breakdown of different foods and fats and stuff like that. Absorption of all nutrients and everything else occurs in the small intestine. The large intestine is designed essentially for fluid absorption and excretion, and then it enters out the backside in the form of waste. Along with the digestive system, we have accessory organs that aid in those processes. So looking at, for instance, the gallbladder, right? Gallbladder produces the bile that is necessary to break down a lot of the fats. So the gallbladder transfers bile, produces the bile, transfers it through little ducts into the stomach, and that bile begins to break down the fats. Once it enters into the small intestine, we'll start to see all that broken down material begin to absorb, and we'll get the nutrients out of it that we can. So again, a handful of different accessory organs. I'm not going to go through everything in detail. It is your responsibility to read up and understand all of the primary and secondary functions of everything there. The integumentary system, aka your skin, functions. There's a handful of different things. As we can imagine, though, insulation, as far as temperature regulation goes, and general protection are its primary functions. You'll see there, assists with water balance. We're able to store quite a bit of moisture within our skin. We can draw that moisture out if we need to, or we can excrete it in the form of sweat to help us cool ourselves down when necessary. So a lot of different things. The shock or impact absorption, it doesn't do much in the way of that. We can't look at a body or at a person's body and think, oh wow, they've got more shock absorption than another person does. Although fatty tissues and stuff are going to aid in protecting some organs, generally speaking, we should treat all patients the same with respect to mechanism of injury and assumed underlying or internal injuries that they may have. 3 different layers of the integumentary system. You've got here your epidermis, dermis, and subcutaneous layers. The epidermis layer is a layer that we can see as we look at our skin. It is primarily developed of dead skin cells. The dermis layer has all of your smaller vessels, so the venules, arterioles to some extent, but for the most part it's going to be a lot of the capillaries. And then down below that is a subcutaneous layer where your larger vessels are going to be, including veins, arteries, and whatnot. Looking at this diagram here, there's quite a bit going on there. When we apply this to trauma, we'll talk a little bit about different types of burns, first and second degree burns, but also different types of external bleeding, such from lacerations and even bruising and everything else. So understanding the 3 layers of the skin is going to be important when it comes to assessing trauma. For instance, when we talk about bruising, what actually causes bruising? Well, bruising is actually caused by bleeding within this dermis layer of skin here. So capillaries, venules, arterioles, something like that gets ruptured. You have blood that's dispersed throughout this dermis layer of the skin, and that's what causes the discoloration or the bruising. How does that relate to swelling? Well, swelling, let's say that this section of skin gets hit by a baseball bat here. Obviously, we're going to have bruising as these vessels get ruptured within the dermis layer of skin. But if there's enough energy that transfers through to the subcutaneous layers, we'll start to see some ruptures here also. And as the bleeding occurs in the subcutaneous, it actually pushes up and displaces the dermis and epidermis layers. So that's where we start to get swelling. So swelling is derived from bleeding within the sub-Q layers, and bruising is derived from bleeding within the dermis layers. The endocrine system, typically known for its hormone production. We'll look at diabetes as probably one of the major components of the endocrine system throughout this semester. The production of glucagon and also insulin are 2 major hormones that the body produces for sugar use. So we'll get into that. The adrenal glands we'll talk about when it comes to things like the fight or flight mechanism and all of your catecholamine releases. So a few different components of the endocrine system there and some of their primary functions. Again, something to look over. The renal system. Renal system helps with Fluid balance also. So it includes the urinary system that allows us to filter through the kidneys, excrete excess fluids, and maintain those overall balances, and also flush out some of the toxins in our body. So again, a few pictures and primary and secondary functions. Ureters and urethra are also included. Ureters traveling from the kidneys down to the bladder, and then the urethra traveling from the bladder out through the vaginal canal or through the penis. Reproductive system, we'll get into this pretty heavy when we talk about childbirth, but this stuff also applies from a medical and both trauma standpoints. Trauma to any reproductive organs can be pretty catastrophic, more so for females than males. The female reproductive system has a lot of vasculature that is associated with it, and trauma or infection both to those areas could put a patient into shock potentially. And that should wrap us up. So this was a shorter presentation compared to the amount of information that's contained. I want to again reiterate that just because I didn't elaborate on every slide does not mean that it's not important. Every single slide, every single piece of information in this chapter is of the utmost importance, and it's going to be on you to really go through, utilize flashcards, utilize the resources through My Brady Lab, go through and review this material, take notes, do what you need to do. But primary and secondary functions of each and every one of the major systems that we talked about today is something that you will have to have a very, very detailed understanding of. You will be quizzed, it will be on exams, and it will be required of you in practice or application of your skills. So thank you very much for taking the time to listen to this chapter. I hope it offered a little bit of insight to you. And if you have any questions, reach out to one of your instructors. Thank you.